In this talk, I'm going to give you some background to the PERCH project. I'm going to give you the rationale for clinical standardization. I'm going to briefly describe the training program and the results of the evaluation, outline a few challenges that we've had, and tell you about the next steps. Approximately 150 million new cases of pneumonia in children less than 5 occur each year, 95% of them in low-income countries. And about 10% of these, that's 11 to 20 million cases, are severe enough to require hospitalization. And of the 8.8 million deaths that were said to have occurred among children less than 5 in 2008, 1.5 million of them, that's nearly 20%, were caused by pneumonia. And then if we look, at least Anthony Scott looked about 15 years ago at the causes of severe pneumonia in HIV-negative children in low-income countries, we'll see 10-15 years ago, strep pneumoniae and Haemophilus influenzae were responsible for 50% of cases, and in another 25% of cases, no pathogen was identified. But that was 10 to 15 years ago. And we need new data for a number of reasons. One, the distribution of pathogens is changing. The introduction of Haemophilus and pneumococcal vaccines is reducing the relative importance of these two pathogens. And furthermore, HIV, urbanization, drug resistance, and economic growth have all had a tendency to change the distribution of pathogens. Furthermore, we know that we can now identify pathogens using novel molecular methods. And without new data, the evidence guiding vaccine development and pneumonia treatment will no longer be an accurate representation of pneumonia etiology. And so the consequences of that can be ineffective treatments, unnecessary antibiotic resistance, a misalignment of vaccine development priorities with pneumonia burden, and a missed opportunity to save lives and improve health. So, we need PERCH. What is PERCH? The acronym stands for the Pneumonia Etiology, American style, Research for Child Health. And it's a research project that aims to improve the evidence base for pneumonia prevention and treatment in developing countries. It's supported by the Bill and Melinda Gates Foundation, and it's coordinated by Johns Hopkins Bloomberg School of Public Health in the States. The objectives of PERCH are to describe the etiology of hospitalized pneumonia in children 1 to 59 months for representative settings in the developing world, to therefore assess the role of known, under-recognized, and potentially novel viral, bacterial, mycobacterial, and fungal pathogens. Secondly, to assess the risk factors for infection and disease from novel or under-recognized pathogens, determine patterns of antimicrobial resistance, and produce a global model of pneumonia etiology and risk factors, which we hope will guide the development of new, improved policies for prevention and treatment. What are the key features of PERCH? Well, it's a large international case control study taking place in 7 countries in Africa and Asia, in both rural and urban settings, and with varying HIV seroprevalence rates, and at different stages of introducing Hib and pneumococcal vaccines. An important feature of the study is that we are using standardized clinical, radiological, laboratory and data management methods and state-of-the-art diagnostic techniques. The PERCH sites, as you can see here, are 5 in Africa: Mali, Kenya, Zambia, South Africa, the Gambia, and Bangladesh and Thailand in Asia. And the study is coordinated from the States. PERCH cases are between 28 days and 5 years. They live in a defined catchment area. They're hospitalized, and they must meet the WHO criteria for severe or very severe pneumonia. And the target, which has now been reached, is for 4,000 cases. The controls are the same as cases in all ways, except that they don't have any evidence of pneumonia. And the target, again, for controls, which has now been reached, is 5,000 controls. So it's a big study. It's a community-acquired pneumonia study, so children who have been hospitalized in the 14 days before admission are excluded. And because we don't want to count the same case twice, if you've been a PERCH case in the previous 30 days, you're also excluded. All children have a history risk factor assessment, a full clinical assessment, and the use of digital stethoscopes to record lung sounds, pulse oximetry, and radiology, and a shed load of investigations, which I won't go into now in the interest of time, but clearly looking for respiratory pathogens in the nasopharyngeal and oropharyngeal route, and also by induced sputum, blood samples for serology, and HIV. Controls have the same investigations, but obviously rather more scaled down. So why bother about clinical standardization, which, doesn't sound like the most exciting thing to be doing, frankly? Well, it's because we want to learn from the BOSTID studies. The BOSTID studies, which were done in the 1980s, it's hugely ambitious epidemiology of acute respiratory tract infections in children from birth to 59 months, taking place in 10 countries. Now, their case definition of pneumonia, lower respiratory tract infection, was based on the BOSTID signs, which is one or more of respiratory rate more than 50, stridor, wheezing, cyanosis, chest indrawing, and crackles, as listed there. But the problem in BOSTID was that 3 countries modified the respiratory rate cutoff, 3 countries used the BOSTID signs and or something that clinicians could as clinical pneumonia, i.e. their Gestalt about pneumonia, and 1 country excluded children with stridor or wheeze. So the result is clinical anarchy, basically, and here we've got the incidence rates for pneumonia in a sample of the countries, and you can see there's huge variation between the countries. Thailand, that sticks to the case definition, has an incidence rate of 10 per 100 child years, and other countries that don't, for example, Uruguay with clinical pneumonia, the incidence rate is markedly greater. So the problem for BOSTID was, is this wide variation in incidence rates between the different countries represent a real inter-country difference in the epidemiology of childhood pneumonia, or merely differences in the case definition? And it makes it incredibly difficult to interpret the data. So if the data don't make any sense, it's tempting to resort to statistics, but even complex statistical models and serious computing firepower can't compensate for poor quality clinical data. So that although clinical standardization sounds dull, it's absolutely underpinning the validity of any study. So we need standardization. So the objectives and milestones of the PERCH Clinical Standardization Programme were to obtain, maintain, and demonstrate clinical standardization throughout the 2 years of PERCH enrollment. There were a number of steps. First, building consensus on what the case definition was and what the component symptoms and signs were. Developing the training materials, running core training at all sites, and 2 rounds of refresher training over the ensuing 2 years of recruitment, with a considerable amount of help from a training website, which we used for ongoing evaluation throughout the 2 years. So what has been standardized? The clinical case definition, the clinical assessment, the clinical measurements, and sample collection. I'm just talking about clinical standardization, but I'll just reiterate within PERCH there's been radiological standardization and standardization of all the laboratory methods as well. So just to go into a few of those, and just to also stress that we had considerable help from a group of wise men, experts, the Pneumonia Methods Working Group, who advised PERCH on all aspects of the study design. That whole rather lengthy process has been written up in Clinical Infectious Diseases if you're interested to know more. So the clinical case definition, we're using the WHO, World Health Organization's definition for severe and very severe pneumonia, which are as follows. It's a child with cough or difficulty breathing, and in both cases that is the entry point. But to have severe pneumonia, the child must have lower chest wall indrawing, and to have very severe pneumonia, they must have one or more of head nodding, central cyanosis, unable to feed, vomiting everything, lethargy or coma, convulsions, this illness. And as you can immediately see, these are very non-specific signs. That they're IMCI, Integrated Management of Childhood Illness, general danger signs. This definition was built for people working in the community without other diagnostic aids, so it's a clinical case definition. And I should stress it's therefore non-specific. So a child with features of WHO-defined severe or very severe pneumonia, and therefore eligible for PERCH, could have pneumonia, but they could also have meningitis, cyanotic congenital heart disease, septicemia, severe anemia, severe malaria. They'd all be eligible. And the rationale for that really is, unless we clearly want to improve the specificity of the WHO case definition, but we can't do that unless we stick to it. And the value of PERCH is that we're getting a lot of detailed clinical information which has been standardized across these 7 countries, and we'll be able to tie it up with the radiological features and all the laboratory work. Of those 1.5 million deaths that were caused by pneumonia, how many were really caused by pneumonia? In other words, how accurate actually are these WHO figures that are banded around about the burden of pneumonia? Well, we hope to find out by doing a study of this size. The second thing that's been standardized is the clinical assessment. And here we're talking about key respiratory and non-respiratory clinical signs. I'm just going to show you this video. And I'd like the clinicians amongst you to look carefully, because in the interests of collaborative teaching, I'm going to ask someone what they think. Okay, a clinician, a brave clinician. What 2 signs did you see? Well, rather than naming and shaming, I'm just going to tell you that child had head nodding. You saw the nodding of the head in time with inspiration. And they also had lower chest wall indrawing, which I'll come back to again later. A real feature of the training was we used a lot of video. A video is worth several thousand words. And we also used some audio. And just to give you a little example of that. Okay, we've got an expiratory wheeze here. So in other words, we standardized the key respiratory and non-respiratory clinical signs. We also standardized clinical measurements. Anthropometry sounds simple, but it can be done incredibly badly unless you actually teach people how to do it. It's meaningless data a lot of the time, particularly height, hopeless. You have to be trained. And I tell you, nurses usually do this, and having to teach this made me realize how incredibly difficult it is to accurately do the length of a child. Extremely difficult. Things like capillary refill time are often done in an incredibly ad hoc fashion with people counting. So we use timers to time the capillary refill time. Pulse oximetry, again, all equipment was used, was the same across all of the study sites. And finally, sample collection. We standardized methods for taking nasopharyngeal and oropharyngeal swabs, for doing induced sputum, and for phlebotomy. So what about the content of the courses? Well, the core and the refresher courses basically comprise lectures and case scenarios, practical skills sessions, ward sessions for clinical signs, with the same multiple choice quiz at the start and the end of the course. The reason for doing that is clearly the start of the course gave me an idea of where they were at, and at the end of the course gave me an idea of how effective the course had been. All courses ended with certificates, prizes, and group photos. The guiding principles were, I strongly believe that research should be capacity building, both on an individual level and an institutional level, that people become better clinicians from participating in clinical research. And for that reason, we also invited non-PERCH Ministry of Health staff to come to all the trainings. Doing a big case control study with 30-odd case record forms and huge numbers of samples to take is stressful, and the training was a real advantage to build teams. We trained people together across cadres, clinicians, nurses and field workers together, so there was no sort of hierarchical structure. And a lot of people who don't necessarily assess clinical science, like field workers, certainly enjoyed learning about them. We used site-specific examples throughout to make it relevant. We used lots of audiovisual material, and the aim was to try and make it interactive and fun, frankly. And all in all, I ran 32 courses in 7 countries and trained in the order of 350 people, PERCH and non-PERCH. I also, over the 3 years, got an awful lot of air miles under my belt. We developed a website for ongoing training. The idea of this is that all the core training materials are on the site, lectures with voiceover with a downloadable certificate, so that the thing about a clinical trial is that over 2 years a lot of the staff leave, so there's no point in just thinking you've trained everyone if you train them at the beginning, because there's huge staff turnover, and I'll illustrate that in a minute. And so you need to have a way in which you can easily reiterate the training. And this was a valuable way in which people could download the materials and do that training in sync with the practical sessions at site. We also used the website for continued learning. There were multiple choice quizzes, and the video quiz was put on the site. And the site would therefore do all the the marking, and I'd be able to download the results. That's the URL, and everyone is very welcome to visit it. There's no point in reinventing the wheel, so we'd be delighted if other research groups want to use these materials in the future. So now I'll come to the evaluation. It's one thing to say that you've trained people, it's another thing to demonstrate that you've had any effect. So has the training worked? Have clinicians at all sites adhered to the protocol, i.e. the WHO clinical case definition, the inclusion, the exclusion criteria? Have they managed to elicit and interpret clinical signs in the same way, take clinical measurements and collect key samples in a standardized manner, and has this been maintained over the 2 years of PERCH recruitment? So the evaluation tools were the multiple choice quizzes, a checklist evaluation of practical skills, and a video quiz. And just to give you an idea of the timeline here, the training, the core training, was done prior to the start of a pilot period. Because it's a complex study, there was a start-up period of between 3 and 6 months in different countries prior to the actual start of recruitment for real. Refresher training was done twice, once 6 months after the start of recruitment, and again at 16 months in the second year. The evaluations, we had a MCQ at the end of the core training, and at the start and at the end of both refresher trainings, with interim multiple choice quizzes placed on the website. And the checklist was done towards the end of the first year of the practical skills, and the video quiz towards the end of the second year. This clearly is the start and the end of recruitment. The MCQs comprised in the main 20 questions. They'd have a PERCH scenario with a video, and the staff would have to select one answer from 4 possible options, therefore testing their understanding of the inclusion and exclusion criteria and their ability to recognise clinical signs. I've indicated the timing points at the end of core training, round each refresher course, and between the refresher courses on the website. And the scores here, this is at different time points: core training, pre and post refresher training, the 2 websites, and pre and post the second refresher training. The analysis being confined just clearly to the nurses and clinicians who actually assessed PERCH cases or controls. And as you can see, the scores by and large are pretty good. There's clearly a spread. No surprise that after training you tend to get better scores at the end of a course than at the beginning with the same MCQ. Just to give you an idea of the spread of results, there are the course scores. These are box plots with the mean, the median, the interquartile range, and the whiskers showing the minimum and maximum, with the exception of the outliers. And again, you can see that Mali's a little bit lower, Francophone country, with the core training here, but by and large they're reasonably comparable. Just to show you the refresher scores, again, not surprisingly getting better after the course in comparison to before. Again, a bit of a spread in some of the countries, but by and large reasonably comparable. And the same for the refresher training in the year 2. Just to show you the split by cadre, clinical officers are clinicians who only have 3 years of clinical training, as opposed to fully trained, the 5 years of medical school that doctors will have. Nurses were also doing a lot of the clinical recruitment in PERCH, but by and large there is a spread, but the results are fairly comparable. The nurses, who also, some of whom were just in the community seeing controls, there was a wider spread. And you can see, if you just see controls on the right-hand side, as opposed to seeing cases and controls here on the left, the scores tend to be slightly less good. Checklist evaluation. This was for induced sputum NPOP swabs and anthropometry, and it was designed as both a training and assessment tool. The procedure was observed by a trainer, and marks were awarded for key steps being carried out as pre-specified in the checklist. And again, the scores here were pretty good in all 3. It's quite a time-consuming thing for the site trainers to do, and so they only did that once towards the end of the first year. The video quiz, there were 35 videos on 6 clinical signs: lower chest wall indrawing, head nodding, deep breathing, central cyanosis, nasal flaring, and whether the child is alert or not. There were 5 videos for each sign, with 10 for lower chest wall indrawing, with the clinicians providing a yes or no response to each video. And again, rather like the checklist, this was a tool for both teaching and assessment. In other words, we included real-life grey cases, because although if you've been taught something and there's a very clear video of a clinical sign, it's fairly easy to get it right, but real life is rather greyer than that. And there's a lot of cases where it's actually quite difficult to decide. The clinical symptoms which are part of the WHO case definition are in blue, i.e. lower chest wall indrawing, head nodding, central cyanosis, and alert child, with a couple of other respiratory signs in black. There were 96 participants who took part in the video quiz, with, as I've said, 35 videos. The mean agreement with the trainer, i.e. that's me, no gold standard, I'm only one person, but it was reasonably good. And the GWET AC1 statistic is rather like Kappa. It's a quantitative indication of the magnitude of agreement between observers, adjusted for chance agreement. And a GWET AC1 of 6 is moderate agreement, and 0.8 is substantial agreement. So you can see, even with training, we're not getting, surprise, surprise, perfect agreement, particularly for something like central cyanosis, which is actually incredibly difficult to see, and even more difficult to photograph. The video quiz was done towards the end of the study. Some of the staff had left, which is a limitation of it. Some of the signs, as I've indicated, like central cyanosis, are difficult to capture clearly on film. This was done as a teaching exercise, so I didn't just give barn door obvious cases, but I included some grey ones. and certain features of the WHO case definition, vomiting, everything, unable to feed, are not suitable for this sort of format. And just to give you an idea of things, this is a child with normal breathing. They've got slight indenting of their sternum, so-called pectus excavatum, but there's no evidence of lower chest wall indrawing. In contrast, here's the second video, and I think you can see fairly clearly that the bony chest wall's going in when this child breathes in. So that's a fairly clear case of lower chest wall indrawing. However, life is not always clear. And this, although you might think this child has lower chest wall indrawing, in fact, this is normal abdominal breathing in an infant. It's got a large and with a rather confusing shadow. So just to give you the feeling that life is not always straightforward. And again, in this case, here's an older girl. She's got rapid respiration. She's thin. You can see she's got intercostal recession, but that's not lower chest wall indrawing. And actually, that is really quite a difficult one to decide. It's one of those grey cases. And that was included in the video quiz and brought down the kappa for lower chest wall indrawing, but it's real world. Okay? So we know there will be grey cases that will either be, I tended to teach that if you're not sure it's not present, but there will still be, even with standardization, there's still going to be a spread of responses. So just to say, I've been spreading the graduates of Oxford University across the world. This is what we gave as prizes at the end of the course. And I just wanted to indicate we have had a few challenges. The sites were incredibly not difficult, they were delightful, but very different in terms of their size, the roles and responsibilities. In some countries it was being run by nurses entirely, others by doctors, but all of them were really excellent. Very different data capture systems in the different sites. There were language barriers. Poor Mali was subjected to all of the teaching in French from my rather rudimentary French, and in Bangladesh and Thailand we used interpreters for key things, although people's English by and large was pretty good. Staff turnover was an issue, and I would just point that out. That is a feature of clinical trials that are lasting over time. And in fact, in South Africa, all the nurses doing the clinical assessments left in year one and had to be replaced. And then there were some factors beyond our control that I'll come to. But just to show you with this survival curve, where entry to the curve is the time of core training, that's the training at the start of the study, and exit is when you leave or the study ends, whichever occurs first. But you can see, just looking at the different countries, there's South Africa, Zambia, Gambia, that they vary. I mean, Kenya and to a certain extent Mali were reasonably stable in retaining their staff over time, particularly Kenya. But some of the countries really had massive loss of staff. And that has real implications for training and really illustrates the importance of having an ongoing active training program if you're going to be certain that your clinicians are doing what you think they're doing. Just to indicate a few challenges beyond our control, in 2011 in Thailand there was extensive flooding. There happened to be a war in Mali during the study in 2012. Kenya had a national nurses strike for three months during the study. Bangladesh last year had incredible civil unrest, but we managed to keep going. Baltimore to capital had Hurricane Sandy, but despite all this, the PERCH show has kept rolling. And all credit to the clinicians and the nurses, everyone involved, for actually maintaining an incredibly high standard of work under unbelievably difficult situation. So what about the next steps? Well, this stuff needs to be written up and submitted as a publication because the PERCH recruitment is now finished. The analysis is incredibly complicated. The results are unlikely to be coming forth until the end of this year, but it's pretty important for us to try and show up front that our data is credible. I would just reiterate that point I made at the beginning, that a lot can be hidden behind class statistics, but actually if your building blocks aren't solid and you haven't done good standardization and of all your clinical and laboratory stuff, then the data is going to suffer. Just to point out at the end to the training tools I would very much like to share with other research groups, and because it's quite a lot of effort to put together training materials, and it's crazy for every single study of pneumonia to repeat the whole thing. Why not share tools? Very much the ethos of I know what you are doing in global health trials. So in summary, I've given you a bit of background to the PERCH study and the rationale for the clinical standardization. I've briefly described the program and the evaluation, the challenges and the next steps. But do want to end by thanking I've been rather a one-woman show with virtual colleagues, but they're wonderful colleagues, the PERCH PIs in all the 7 countries, to blame Anthony Scott for pulling me into the clinical standardization, or to thank him. And the PERCH core team in the States were wonderful, and Christine Prosperi has been churning out statistics left, right and centre in an incredibly helpful manner. But I also particularly want to thank these fantastic teams and people that I've worked with in 7 different countries over the last 3 years, who really have been superb. And of course, the kids themselves and their parents. Thank you very much.